Recording has started.
Well, good morning. Let's just jump right into this. Good morning to everyone, and welcome to the third Gaspar Carrasquer named lecture. It's a real honor to introduce the speaker today. But before I do, let me just say a few words of thanks to the Carrasquer family who has signed in today, setting up this lectureship. Gaspar Carrasquer was one of the founding members of the renal section, University of Louisville School of Medicine. In that sense, Gaspar was a kidney doctor before there was even a discipline. In many ways, he was the consummate nephrologist, being both an outstanding teacher who deeply cared for his residents, fellows, and students, as well as a clinician and also an outstanding scientist. For a period of years, his collaboration with Warren Ream and Manuel Schwartz really set the drumbeat for the study of proton secretion and cation exchange in epithelial cells. He was very much the consummate triple threat, and it was an honor to be a fellow under him as well as a colleague for a number of years. So thanks again very much. Deep thanks to the Carrasquer family for establishing this lectureship. Thank you very much. Our speaker today is Dr. Michael E. Brier. Dr. Brier has been here almost for his entire career. Dr. Brier went to undergraduate school and received his Ph.D. from Purdue University in West Lafayette, Indiana. After completing his Ph.D., he joined a laboratory at Indiana University where he fell in with a notoriously bad crowd consisting of George Aronoff and Fred Luft. There they studied a number of problems that were related to the disposition of drugs in renal failure. And then when George Aronoff was named the division chief here, Michael came and established his research program 1987. His career has been varied in terms of his research. He's studied a number of problems related to drugs and renal failure, but most notably, he's recognized as one of the very earliest people to apply artificial intelligence or machine learning to the study of drugs and renal failure. And in fact, I looked at his CV and I noticed that the very first paper that he published was, I think, in the area of neural networks, a form of artificial intelligence, predicting peak and trough levels in gentamicin. In some ways, he is the father of the use of artificial intelligence in nephrology, something that needs to be recognized and acknowledged. Michael also is an entrepreneurial sort. He has a number of patents as well as established a company with his longtime collaborator, Adam Govenda. We are truly fortunate to have Michael at the University of Louisville and to hear him speak today. Mike, take it away.
Thank you, John. So I'm going to add a few comments about Gaspar too, because I think it's important, and I'd like to thank Carol and Alex and the Gaspar Carrasquer family who have joined us here virtually today. And we had a nice chat before everyone came online. And as I told them, I came to the University of Louisville in 1987, and Gaspar had already been here 16 years. When Gaspar retired, he had been at the university for 49 years. And when we talk about diversity at the University of Louisville, I'd like to point out that there's a number of items of diversity. Gaspar was born in Valencia, Spain in 1925 and lived through the Spanish Civil War. And I can only imagine how that influenced him. And when I did speak to Gaspar and I learned this, I talked to him a little bit about his experience there. And he tells me that he remembers the Germans coming to bomb the harbor where the ships were. And I can only imagine how that would make someone feel and how that might influence them. And I think in Gaspar's case, it made him the gentleman that he is. He came to the United States, became a nephrologist, and participated in this activity as well as Forrest Arnold. I think Forrest probably can count the number of days that Gaspar wasn't in the audience on one hand. And so Gaspar, I think, in the Carrasquer family, setting up this lectureship really honors Gaspar's memory. And remember, when you have someone like Gaspar, ask them the questions now so that you can have the same experience that they have so that they can influence you. So with that said, I think I'll move into our talk, if I can get it to work. Okay, so my disclosures. Number one, I'd like to thank right off the top the Department of Veterans Affairs, where I've worked for the last 25 years and been funded by the department. Some of the work that we're going to talk about today was also funded by the NIH. And I'd like to thank the collaborators on these different projects. We have, as John mentioned, we have some patents on technology that will be discussed, and that we have a partnership with a company. And lastly, I'd like to thank the patients at the VA, the staff at the VA, the patients at the University of Louisville Kidney Disease Program, the faculty for their contribution to the work, because without their efforts and their contribution, we wouldn't be anywhere near where we are now. And lastly, I'd like to thank the internal medicine residents, interns, and staff that took care of me for 18 days when I was in the hospital in January, because without their help, maybe I wouldn't be giving this lecture here today. So thank all of you. So what we're going to talk about today is machine learning. And the lecture is divided into three parts because I attended the lecture that was given by the faculty member from surgery that told us that our attention span is only about 15 minutes long and we have to have breaks in between. And so I've divided this into three parts of maybe 15 minutes each. So in the first part, we're going to talk about what machine learning is, and we're going to use some terms that will help you identify that this is a machine learning approach as you read the literature. Next, I would like to present some current examples of machine learning that are being used in medicine, and finally discuss the work that we're doing here at the University of Louisville in this area. But first, let's talk about advances in medical technology. So back in 460 BCE, Hippocrates was born, and he told us that we should learn by making objective observations and deductive reasoning. So he was the first Sherlock Holmes of our time, and he applied that to medicine. Medicine is marked by innovations that allows us to do things and see things differently, like the invention of the microscope. When I prepared this, I thought Leeuwenhoek was the inventor of the microscope, but I learned in 1590 Janssen actually invented the microscope, and Leeuwenhoek just refined it. We also see that there are other advances like the establishment of germ theory of disease, x-rays, vaccines. I think in 1993, with the introduction of CRISPR, there will be a giant leap in medical technology. But right now, we're going to look at machine learning. And this is something that, if it hasn't already impacted what you're doing, it will in the future, and everyone should have at least an understanding of what we mean by machine learning and learn that it's not just some kind of black box approach. So part one is define what machine learning is. If you go to the literature and you look to see what applications in medicine are being applied in machine learning, you see the top four are diagnosing disease, speeding drug delivery, personalized treatment, which is the area that I'm most interested in, and improving gene editing. Machine learning is defined as a scientific study of algorithms and statistical models that computer systems use to perform a specific task without using explicit instructions. So sometimes we turn the computer loose and let it tell us what it sees. It relies on patterns and inference instead. It is seen as a subset of artificial intelligence, and in fact, machine learning is math. Machine learning is statistics. And these are all, if you had a Venn diagram, they would all interact and they really overlap. And so some of the things that you're applying already might be machine learning. They are useful for classification and prediction. I put this slide together because I want you to be able to understand as you're reading the literature and you see some words that you maybe haven't seen before, that those could be thought of as machine learning applications. The ones that are traditionally in the statistical realm are those of like regression techniques, linear, logistic, stepwise, decision trees. You may have heard of a CART or a CHAD clustering, k-means and k-medians, and dimensionality reduction. Principal component analysis is used many times in the biomarker market. And so these are things that you may have heard of before. What you may not have heard of is ridge regression, naive Bayes, Gaussian Bayes, a priori or ECLAT. You may have heard of artificial neural networks, and we got our start looking at artificial neural networks, and I'll show at least one application of what we've done with artificial neural networks. But if you look at the literature right now, and you look at the articles that are being published in our top journals like the New England Journal of Medicine, the Lancet, and Nature, the area of machine learning that is exploding right now is deep learning. And we'll go into that a little bit deeper as we look at some of those examples. And one of the final ones I just want to highlight here is the idea of reinforcement learning, which is what we're going to use at the end of this talk to do some drug dosing for multiple drugs for an indication. There are different styles of learning. Since we're talking about machine learning, we have to, for whatever reason, make up new terms for everything. And so in machine learning, they like to talk about model fitting as learning. And there are two types of learning, supervised learning and unsupervised learning. If you take data from an ELISA, for instance, and you model that data using the traditional sigmoidal logistic modeling technique, you have an input, which is a reading on a device, and you know what that concentration was. That's an input data pair that has a training data with a known outcome. That would be a supervised learning environment. So we've all done supervised learning, if it's linear regression or logistic regression. Where machine learning really expands our ability to do things is through unsupervised learning, where you have data that are not coupled with a known outcome. And you ask the computer to look at all of this data and group it into patterns that we can then use to make predictions or categorize patients. And then you can get a mix of the two different techniques together as semi-supervised learning. The process that we use in machine learning follows some regular steps. And the first one is the training of the model. And we repeat this performance until we get a satisfactory result. So what we do, the first step is always to get data and pre-process the data. And what I would say in the past was about 85% of my time is spent working with the data and getting it into a usable form. And when I say usable form, I say if we're pulling data from an electronic medical record, there may be missing values. How do we handle a missing value in a data set so that we don't lose that individual from a prediction? The next step is feature extraction. And as I said before, they have designed a new lexicon that we have to understand. And feature extraction is just asking, what covariates are we interested in? Are we interested in age, gender, sex, height, weight? Then we train the model. So we have some kind of mathematical model and we have data. And the mathematical model is defined by parameters that we estimate. And so we use the data to estimate the parameters so that the model reproduces the output that we're interested in. Then we can do some optimization of those parameters by maybe holding some of the parameters fixed in the model and letting some others vary. And finally, we have the model which we can apply. And if we look at that model and we do some simulations, we don't like it, we can always go back to the beginning and start over, get more data if we're missing data in a specific area. But this process can be repeated multiple times. And we'll see in the last example where I'll show how we did this multiple training sessions to get to the answers. And finally, what we want to be able to do, of course, is to predict. So we're going to capture data. We can capture data from the electronic medical record. We can write a script that pulls data from University Hospital that looks at dates of admissions and diagnosis and predict whether or not the patient's going to go into the ICU or what have you. The feature extraction, of course, is that what data in the electronic medical record do we need to have in order to run the model, and then finally predict. So this is something that's common to every machine learning example. So now we're going to move into some examples. And I have open on the right-hand side of my screen here the chat box. So if somebody has a question that's burning at this point, you can type it into the chat box. And of course, if I see it, I'll answer it. But even at the end of the presentation, feel free to type your messages in there. And if I don't see them, Jason will probably break in and let me know that somebody has a question. So the first application that I want to talk about is that of diabetes, because there has been a number of publications using machine learning in diabetes care. And these investigators did a kind of a review of the literature, and they found 450 clinically relevant publications. About a quarter of them were automated retinal screening. Machine learning has been used for a long time for pattern recognition in image analysis. And so it's an easy extension to look at this. And so you can expect to see machine learning algorithms reading x-rays, reading MRIs in the future. In this case, they looked at retinal screening. 126, a quarter were clinical decision support, a quarter were on population risk stratification, and a quarter were built for the patient, something that they can run on their iPhone that will allow them to see calories in they can actually scan barcodes of something that they're going to eat, and it will give them all the information, nutritional information they need to know. In 2018, two things happened, at least. One was the first medical device for the artificial intelligence to screen for retinopathy was approved by the FDA. And the second was an AI-powered continuous glucose monitoring system was approved for ages 14 to 75. So in diabetes, we're already using machine learning for everyday care of the patients. There were AI apps for smartphones that were developed to guide nutrition. I said before, wound care. Actually, you can take a picture of a wound and it will tell you information about how to take care of that wound. And anybody that's watched TV will know about IBM Watson. There's a lot of commercials talking about IBM Watson and how it's integrating healthcare. And in fact, they used an integration of IBM Watson and continuous glucose monitoring, and they found that there was a 36-minute per day increase of the glucose concentration in time in range, but probably more importantly, a decrease in 30 minutes above 180 milligrams per deciliter, and a decrease of 6 minutes per day of hypoglycemic events. I'm going to delve into this a little bit further, and here's a review of ophthalmology where they show how they use artificial intelligence and, as we talked about before, deep learning or deep neural network to do an image analysis of the retina and predict whether or not they have diabetic retinopathy. And so what they do is they take hundreds and thousands of pictures of retinas, and they have an expert come in and say, yes, this is diabetic retinopathy, this is not. And they digitized this image, and they fed it into this system of a deep learning neural network, and it would be predicting whether the patient should be referred for diabetic retinopathy or not. And so this is one of the applications that has received FDA approval. The other application that was presented recently at the American Diabetes Association in 2020 is the idea that we can have a algorithm predict the glucose concentration and compare it to what the user's continuous glucose monitoring system had. And they do a very good job of predicting that based on what was eaten by the patient or what drugs were taken. Importantly, they use 4 days of information to train the system to understand the patient, and it was personalized without using any glucose. So the only information that the model saw to predict what the glucose concentration was is this information. They didn't have any prior glucose information, and so you can see what happens to the patient's serum glucose concentration over time, and therefore you can plan proper bolus administration of insulin. One of the other areas that machine learning has been applied in is in cardiology, and they used what's called a random forest. Random forest has been around for a while, and one would typically think of it as a statistical technique, but today we're going to just introduce it as a machine learning because it exemplifies how we're taking large input information and using it to make predictions. In this case, there were 33,000 women from the Women's Health Initiative, and they had 477 ECG biomarkers that they used to make the predictions of mortality. They had 1,300 deaths, and important to a machine learning technique is that typically what you do is you take your data and you split it into two groups. One group you use to train the model and determine the weights of the model, and then the model is fixed and you test into another group. That way we can see if the model is able to generalize to the population in general. The other thing that I want to point out here is that these models should always be compared to something else that we're already doing. In this case, they compared it to Cox regression, between the random forest and Cox regression, and made comparisons between the two. Unfortunately, the Cox model failed. And those of you that may have had some experience in doing modeling, when you have 477 biomarkers and you enter them into a Cox model, there's a problem of multi-collinearity, where you may have one marker that is the same, basically provides the same information as another marker, and the model may have a hard time dealing with that. The random forest approach, however, didn't have it, and it resulted in 20 variables. And not only did they result in variables that were predictive of mortality, but they could look at those variables and they could determine that they had meaning in their prediction and that they were markers of autonomic tone, atrial conduction, and ventricular depolarization and repolarization. So not only are these programs and machine learning applications available to make predictions, they're also able to tell us something about the environment that they're predicting in that we can do further exploration. What they did in the end was they took these 20 variables that were identified by random forest and did the Cox, were successfully in converging a Cox regression at that point. And this is just what a random forest looks like. So down here at level 0 is the first pass through the data, and the most important parameter in determining mortality in these 33,000 individuals was income. So in this case, income is a surrogate marker for a lot of other things: access to healthcare, access to proper nutrition. And then the people that had low income, the next important thing was were they treated for diabetes or not, versus those that had the higher income was looking at P-wave area. And the model then progresses. It builds a force. So every time that it has a split, it then tries to split the next most important variable. And so you can see that we have diabetes in here, P-wave, ventricular weight, age, smoking, systolic blood pressure. Age comes back in again. So this may be a demarcation between, let's say, age higher than 50 and less than 50, and this may be one that maybe there's patients greater than 70 and further segregating the population. So that's random forest, and we actually use that quite a bit as a statistical technique. People in engineering like to have challenges, and One of the challenge was the SAGE BioNetwork's Dream Breast Cancer Prognosis Challenge. In this challenge, they took a data set that everyone was allowed to have access to of about 2,000 patients. 350 groups applied to do predictions in this data, and the results were published in 2013 in Science Translational Medicine. They hypothesized, these authors hypothesized that there were attractor metagenes that would be predictive of survival. The three, once again, were able to come up with some meaning from the results, and they found that the three universal attractor metagenes used in the final model had to do with mitotic chromosomal instability, mesenchymal transition, and lymphocyte-specific immune recruitment. I guess the oncologists that are in the audience will be able to tell us why those things are might be important, but there could then be further research looking at these things specifically due to the results of this analysis. Now, I am not an individual that has really seen what their metric was, how successful they were, but they use this criteria called the concordance index, where if you have a concordance index of 0.5, that's basically like random chance, so you'd flip a coin whether they're going to survive or not. In this case, the winning model had a concordance index of 0.756, so that was better than 349 other groups. And what this means is that the model correctly orders two randomly selected patients' survivals 3 times out of 4. So if you select randomly 2 patients from the data set, and you say which one's going to survive longer than the other, it did that correctly 3 times out of 4. I don't know if that's clinically important, but it was certainly a metric that they chose to compare the groups on, and certainly this model was the one that won. And here is what that model looks like in graphical form. They have information, so this is the information that was used to make the prediction. This is what the data set looks like, survival information, where 0 means non-death, 1 means death, and this is the amount of time that they were at risk. They did a Cox regression, they did a Bayesian regression, they did a nearest neighbor, they used empirical selection where an expert came in and said, these are the important factors in predicting whether they would live or whether the patient would live or what their survival would be. And then they did a Cox again. And as you can see, this is a very complex approach, more complex than anything that I've ever worked on. But you can see that without modern computing, we would never be able to perform these types of analyses. Now, I promised you that I'd talk a little bit about deep learning, because that's the machine learning approach that is used in IBM Watson, and it's the one that is garnering the most importance currently in the literature. And in this case, this was published in Lancet Digital Health, and it was a meta-analysis of 31,000 studies where they used 82 to predict disease from medical imaging, and they compared it to what the healthcare professionals said. So they took the training data, were 25 studies, and they tested in 14 studies. They concluded that the diagnostic performance of deep learning was equivalent to healthcare professionals. I leave it up to you to decide whether that's important or not, but remember, a computer is never tired. They didn't have a fight with their spouse the night before, and so maybe there's an advantage to some of this, but at this point they didn't see any advantage, superiority of the deep learning technique. But let me tell you what deep learning is. So on this slide, I have 2 graphics. One is an artificial neural network of multiple layers that uses inputs to predict something. And in the case of the current application, they're using image analysis, and they're predicting mortality or disease. Each one of these nodes can be summarized and can be compared to a logistic regression analysis, right? So if you're familiar with logistic regression, what we're trying to do is we're using age, height, weight, etc., to predict some outcome that's a 0 or 1. In this case, it could be survival, right? And what we do is we take each one of these age, we multiply it by some weight, which is determined during the model fitting process, and then we use a nonlinear transform. So we take that number and we scale it between 0 and 1, such that if it's 0, that means the event doesn't occur, and if it's 1, that means the event did occur. So this is a nonlinear regression, and what we're trying to do is we're trying to take data that's in multiple dimensions, and we're trying to make it linear. And each one of these layers is doing a transformation of the data in order to try and separate case from control. And that's what deep learning is. Here's the results. So these are receiver operating curves that look at the sensitivity and 1 minus the specificity of the test for predicting the outcome. Here we see the healthcare professionals, and we have, for comparisons purposes, we have the summary point, right? So the summary of all the analyses for the healthcare professionals is here, and here for the deep learning. And we can see that the deep learning had a little bit better sensitivity and specificity, but the authors concluded that it was no different than the healthcare professionals. So this is an example where we've shown that deep learning can reproduce what individuals can do. And I think that's an important takeaway message from this analysis. Here we're going to show a nephrology example, and this one is a clinical application to predict acute kidney injury in patients, and it was published in Nature last year. Once again, we see the same receiver operating curves, and in this case, the authors made no comparison to any other analysis, and in my opinion, this is actually a failed application because they did not make a comparison to other another technique, and that the in order to pick up one case of acute kidney injury, you have to look at 3 individuals. So you needed to say that 3 individuals were going to have AKI, and only one of those would. So if we had a method to treat these people, you would treat 2 patients that did not develop AKI. So finally, I'm going to go through the last 15 minutes and talk about what we're doing at the University of Louisville. We're going to talk about prediction of AKI because this is something John Klein and I did in 2003, I think. We're going to talk about treatment and anemia, and if I have time, I'm going to talk a little bit about metabolic bone disease. And so in 2003, we did exactly what the people did in Nature 15 years before, but this case we compared the results of an artificial neural network in predicting delayed graft function, which is a form of acute kidney injury, and we compared it to logistic regression, and you can see that both of the curves on the ROC, the receiver operating curve, are superimposable, in that approach had no benefit over logistic regression. So what we're applying here is control engineering. Adam Govenda is the person that has done the bulk of this work. He is a Ph.D. computer scientist, and he is the one that has really innovated the work that we're doing here. In control engineering, you have sensors that monitor the system. They output to an actuator, which is the physician, and control is automatic. And similar applications are automatic pilot in airlines and the cruise control in your car. There are two types of control system. One is open loop control, which just says basically I fire and forget. I have a prediction and you use that, and I don't think anything further about it. But what we use is closed loop control, where you have a prediction and you then compare the output to what is actually achieved, and that error that is then fed back into the system so that we can adapt the system on the fly to a changing environment. So for instance, if a patient has developed an infection during their hospital stay and that changes their therapy, the computer would be able to pick up on that and make some alterations due to it. The advantage of the techniques that we're using, which is called model predictive control, is that we can use closed loop control, we can use multiple variables, we can incorporate constraints into the model, such as for anemia, rate of hemoglobin rise, what doses are available, what's our maximum dose, and the frequency of dose changes. It's easy to formulate as a constrained problem. It uses an explicit model in that we have a model that's parameterized in the terms of red blood cell lifespan and sensitivity to erythropoietin, and it's solvable by standard mathematical software. The information that we have is we have past treatment information on a patient, and we know where we want to be on this red line. And we know where the patient actually is, and we know the doses of the medication that we gave. And we can use that to predict forward in time. And we don't just predict the next observation. We actually predict 3 or 4 observations ahead, because red blood cell lifespan is about 90 days in patients on dialysis. And so in 30 days, we're not going to be anywhere near the steady state concentration. So what we want to do is we want to predict a dose that's going to get us to at the future to be where we want to be. And we use this information to provide dose information. And this is how we've done it in anemia management. So we have the model, which I said was parameterized in the form of red blood cell lifespan and sensitivity to erythropoietin. And we have an optimizer which provides to the model every dose. It looks at the response and it compares that response to where it thinks we need to be the next observation period, and it selects that dose and it provides it to the patient. During the next round, we know what dose the patient got because we gave that dose. We know what the response was, and we can provide that response information back to the model, compare it to the predicted, and see what the error is, and then make an adjustment in the model and run the process again. So we use feedback control in order to optimize drug therapy. Currently, we use the information in the package insert. And the package insert for anemia management says to consider the following: the rate of rise, the rate of decline, ESA responsiveness, and hemoglobin variability. But it's left to the practitioner to understand what those terms mean. A single hemoglobin excursion may not require a dose change. Do not decrease or increase dose more than once every 4 weeks. Do not decrease. You can decrease more often if needed. And it gives some examples of what you might change the dose to depending on where the patient is. And so our physicians took that information and they created this algorithm. And so a physician would ask the question of where's the patient's hemoglobin? Is it above? Is it within the range? If it's not, if it's below 10, what am I going to do? Are they already on EPO? Is it trending up? And it would tell us how to increase and decrease the dose. And this was state of the art and still is state of the art for many dialysis facilities. So we compared a machine learning approach to that approach. This is data. And so when we developed the model of our patients, we had this information. And if you look at it, it actually looks like hemoglobin concentration falls as EPO dose increases. But using some of these fancy machine learning techniques, we used a fuzzy C-means clustering algorithm to tell us how many clusters are in that data set. And as you can see in this example, we could cluster the patients into two groups of normal responders and poor responders. We further worked on that, and we actually found that there were 5 categories that patients fell into. And so that initial data set that we looked at, where it looked like hemoglobin fell as we increased EPO dose, what we see is that we have 5 categories of individuals that varied from extreme hyper responders to hypo responders. And so we built our model around that. And you can see here the graphical representation of that, where we have a model for extreme hyper responder, for hyper responders, intermediate responders, hypo responders, and extreme hypo responders. And we use information on what the hemoglobin target is, what their current hemoglobin was, what the rate of change was, and the amount of ESA or erythropoietin that they're receiving. And we categorize the patients based on this information into response categories. We then, for each one of these response category, we calculate a dose of ESA to give. Then we look at individual patients and find what category they belong to. And in this case, patients can be a partial member of any one of these. And so, for instance, a patient could be a 90% extreme hyper responder and a 10 hyper responder. And so we would take the dose provided by this algorithm, multiply it by 0.9, and the dose provided by this and multiply it by 0.1, sum those together, and that's the dose that we're going to apply to the patient. We did that. We published that in 2014 as a randomized controlled double-blind clinical trial in 60 patients, 30 randomized to standard treatment and 30 randomized to machine learning, and we got the following results. The goal of the study was to decrease hemoglobin variability, and here we see the 2 different hemoglobin variabilities that we're interested in. We have intra-individual hemoglobin variability, so this is hemoglobin variability in that same subject over 12 months. As you can see, this curve is higher and more narrow than this one, so we decreased intra-individual hemoglobin variability and markedly decreased between subject variability. And so we're able to show with statistical significance and a properly powered analysis that machine learning can decrease hemoglobin variability. It had the added effect of decreasing the number of transfusions in this patient population. As you can see here, the black bars are the control group transfusions, and the open bars are the treatment group. And this is the only indication for using erythropoietin in this population to decrease the need for red blood cell transfusions. And so we were able to show that in this small study. We have since taken that algorithm and applied it to a larger population. So the first study, randomized controlled clinical trial, is in a population that has inclusion-exclusion criteria, and we used it to look at whether or not we could decrease hemoglobin variability. But we don't know how that extrapolates to the population in general. And so here's 2,000 patients, and you can see in this case, the drug that was given is darbepoetin, which is a longer-acting erythropoietic agent, and we can compare it to a 3-month period prior to the use of the tool, which we call Strategic Anemia Advisor, and then we have 12 months of follow-up. And here you can see that the median dose was 87 during the control period, and that it fell to 67 to 43 during the next year. And so we can see that there's a substantial saving of exposure of the patient to this agent, which has a black box label warning warning us not to give high doses of ESA. And so I think we are using this technique. We've demonstrated that we can decrease exposure of patients to this agent. Since that time, we have now expanded the use of this tool to approximately 150,000 patients in the United States. And rather than the 40% or so reduction that we saw in the 2,000 patients, in this 150,000 patient sample, we see about a 25% reduction in drug exposure. And as you can see here, we decrease hemoglobin variability, but it takes a while. So anyone that plays golf, if you went and had golf lessons and they changed your swing, you know that your golf game gets worse until you get used to changing your swing. The same thing happens in this environment, where if you take and you disturb the system, you go from one drug to another drug, or you go from one algorithm to a new algorithm, it takes time for the system to come back into equilibrium. In this case, it takes about 4 or 5 months for that to occur. So we've presented our first work in artificial intelligence in 1994 for dose prediction that John Klein mentioned at the beginning, where we predicted peak and trough gentamicin concentrations. We did our first randomized controlled trial using an artificial neural network in 2010. We did the second, published it in 2014, and the data that I showed. The University of Louisville licensed this technology to a company that has then taken that and expanded it to use into about a third of the dialysis patients in the United States. And we now have it as a 510K medical device. So it takes a while for us to take something from concept to actually using it in patients, but I think we have successfully demonstrated that we can do that with machine learning. I'm going to go through these last few slides rather quickly because of a time constraint, but what we are doing now is we're looking at metabolic bone disease, and this is research that is funded by the Department of Veterans Affairs with Eleanor Lederer, the former chief of the Nephrology Division and acting chair of the Department of Medicine, as the PI. And so there's a progression. As kidney function decreases, we have phosphate retention, and that ultimately leads to hyperparathyroidism. Once again, we can apply the same techniques that we did in machine learning previously that we talked about. In this case, we're using what's called reinforcement learning, and the reason that we're using reinforcement learning is that this is a model of how humans learn. And what we have is the environment, which is the model, and we provide rewards for how well the model predicts what the action is going to be. The agent is a computer model that tells us how to do different doses, and the state is the current state of the environment, which is what's the current phosphate concentration, calcium, PTH, calcitriol, FGF23. And so what we're trying to do in this case is we have what's called a quantitative systems pharmacology model. So we model all these different organ systems, and we model the flux of calcium and phosphorus between the bone, the extracellular fluid, vascular smooth muscle during dialysis, how this interacts with vitamin D and calcitriol production in the kidney, and parathyroid hormone production. Here is the data that we have to fit that model. So this is the calcium concentration and phosphorus concentration, and the red line is the result of the model at this point. So we're in the model refinement stand at this point. We're refining the model, so we can see the results for calcium phosphorus. We can see the results for calcitriol and PTH. And finally, we can see the results for FGF23, and FGF23 is the phosphorus hormone produced in the bone that controls phosphorus metabolism. we have trained several different agents using different cost functions. So if we want to optimize the percent of PTH in range, that may lead to a different result than if we want to minimize the amount of drug that's used. And so in this case, we have 5 agents that we trained, and each of those agents was more or less successful in keeping PTH in range or calcium in range. And we chose, for further analysis, this agent 1463 because it does a good job of keeping PTH in range, but it's minimizing the effect of using the calcium mimetic, which is the more expensive agent and the one that causes the most side effects in this patient population. In simulation, we have simulated the use of this machine learning approach, and you can see the phosphorus, calcium, and PTH concentrations going through time over a number of months, where the red line is where we want them to be. And so the system is trained to provide doses of phosphate binder, doses of calcitriol, and doses of cinacalcet to this patient in order to optimize these parameters. When we do this simulation in 100 patients, you can see that calcium over time is increased to about 9.3. You can see that phosphorus comes down to about 5. And most importantly, we can see that PTH falls over time to well below 500, which is what we're trying to achieve. So we're in first clinical trial right now with this technique, and hopefully we'll be able to, in the future, be able to provide information about how well this is working. And so in conclusion, I want you to understand that machine learning is just math. And when somebody says they're using a machine learning environment, it's not really a black box approach. It's a mathematical approach. It's a statistical approach. Machine learning approaches exist and are increasing. And you may be exposed to a machine learning approach, and you may not even know that it's being used. And so you have to maybe pay attention. I have a friend that's an airline pilot, and he flew the MD-11, and every now and again he's required to let the plane land itself. But he didn't tell you that he was going to let the plane land itself. And so that brings up some ethical considerations. And so if you want to look at what those ethical considerations are, you can go to this Lancet 2020, Volume 2E 2223, and look at what those may be. And I think that's a talk for a different time. But at this point, I'd like to conclude the presentation and look to see if anybody wants to make any comments. So thanks.
Thanks, Mike. That was absolutely fantastic. I think we have time for just a few questions. And the first one comes from Dr. Lederer down in Dallas. And if you have questions, please put them over in the chat area. It just makes it simpler, and we don't talk over each other like presidential debates. If this approach holds such promise, Dr. Lederer asks, what do you think the biggest barrier to creating more of these models and implementing them?
So, unfortunately, the biggest barrier is the audience that we're talking to right now, that we've experienced. Physicians are somewhat reluctant to release control of their patients to a computer. And so what we have to do is we have to demonstrate repeatedly the ability of these systems to make these predictions. All of the publications, at least in the nephrology literature right now, that talk about machine learning are really just hypothetical applications, and we're actually one of the few that have developed a clinical tool that's actually being used. So it's going to take a while to get general acceptance, but the biggest barrier is that as I explained before, when you go in and you start using these tools, the patient may actually not respond the way that you want them to respond immediately, and you may abandon the tool before it has the ability to uh, adjust to the patient and provide the proper responses. Now, in an acute setting, that's a dire situation, right? So if we can't wait for somebody to get there, if we're treating somebody for hyperkalemia, I can't wait 5 days for that to come into balance, and I need a response right away. And so we have to demonstrate that these tools and be willing to merge the need of the physician to rapidly obtain some objective versus the ability of the tool to predict in maybe a more relaxed environment.
Okay, I don't see any other questions. I'd like to ask one before we sign off. It's almost
Sure.
9 o'clock by my clock. Michael, follow up to what you were just talking about is that, we've all seen publications where machine learning approaches either were equal in performance or superior in performance in some settings to things like diagnosing skin lesions, interpreting chest x-rays. Are we going to see a day when machine learning actually decreases the demand for the total number of physicians?
That's certainly a possibility. But I think that we're risk adverse, at least at this point in time, we're risk adverse. And as my allusion to the pilot that's landing the plane, the new 737, although let's leave the 737 MAX out of this, the 737, the 757, the 767 are the 747 are all capable of being flown from point A to point B completely by computer control and landed. In fact, I have my pilot's license. And when I was looking at what some of these people can do, because when you're approaching an airspace, you have to be at a certain place at a certain altitude at a certain speed. The pilot right now is sitting there plugging in those numbers, and the computer does all that for him. Whereas when I was learning, I had to juggle all of those things. And so we in airline, were risk adverse, and they actually were the first area where they went and did like an M&M, right? When they had airline accidents, they went in and they evaluated what happened so they could make them better. So I think it's the case in the airline industry. I think that medicine will move there, but we're so risk adverse that I don't think that it'll be anything that will happen anytime soon. That will always, at least for the foreseeable future, having a physician checking these. And what I think what we'll do is we'll have the computer will say routine, 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 routine. Oh, wait, this is somebody that you need to spend some time on. So actually, you'll be able to spend more time on the patients that need your input by using this technique. So right now you have a patient in clinic, you have 15 minutes with them, and if it's a complex case, then you have to spend 30 minutes with them. Then your clinic runs long and your patients get upset. So I think that actually the number of physicians aren't going to necessarily change, but I think the amount of time that you are able to spend on the complex patients will be better utilized, at least in the foreseeable future.
Okay, we are past the top of the hour, but I wanted to thank again the Carrasquer family for their generosity and for sharing Gaspar with us for all of those years. Thank you very much. Everyone have a great day and stay healthy.
All right, thank you.
Thank you, Dr. Klein. Thank you, Dr. Brier and the Carrasquer family, and thank everybody for joining us this morning. That's a wrap, and just next week will be Dr. Moksha Gundam from